All right, good evening, everyone, and thank you all for coming to this webinar on orthopedic care of the transgender patient. We've assembled an all-star faculty tonight for this essential topic and are looking forward to an exciting and informative session. I'll go over quickly our agenda for the evening. My name is Corinna Franklin. I'm the Director of Sports Medicine at Shriners Hospital in Philadelphia, and I'll be moderating. Our first talk will be by Dr. Julie Balch-Samora on caring for the transgender patient. She is a pediatric hand surgeon at Nationwide Children's Hospital. Next, Cordelia Carter is going to discuss orthopedic care for the transgender athlete. Dr. Carter is the director of the Women's Sports Health Center at NYU. Following that, we'll have Ann Danoff discussing the medical treatment for transgender care. Dr. Danoff is the former vice chair of medicine for the Division of Endocrinology at the Perelman School of Medicine. After that, Dr. Tetreault will be talking about how to be an active ally to transgender patients. Dr. Tetreault is just finishing orthopedic residency at the University of Colorado and will be going on to pediatric orthopedic fellowship at CHLA this summer. Dr. Lattanza is going to discuss leading change, creating a culture of inclusion. Lisa Lattanza is the chair of the Department of Orthopedics and Rehabilitation at Yale. And then finally, we're going to have a Q&A with all the panelists. So as the talks are proceeding, if anyone has questions, please put them into the Q&A and I will address them at the very end. So thanks very much for everyone's attention, and we'll get started with Dr. Samora's talk.
Thanks, Dr. Franklin. Can everyone hear me okay? Great. So I will start with talking about just simple taking care of transgender patients. I have no disclosures that are relevant to this talk. The objectives for my part of this webinar this evening are to simply better understand the relevant vocabulary, to recognize the need for culturally competent care, to identify methods to provide best care to transgender patients. Starting off with vocabulary, sex is that which is assigned at birth as male or female based on external anatomy, chromosomes, or hormones. Gender, on the other hand, is a social construct rooted in a particular culture's associations with masculinity or femininity. As you can see this child's book below, boys have trucks, and girls have dolls. What happens when those social constructs are challenged, such as this picture where the girl's playing with the truck and the boys playing with the dolls? Gender identity is a person's inner sense of being a woman, a man, another gender, or having no gender at all. This does not necessarily align with the sex a person is assigned at birth. Cisgender means that there's actually a concordance between gender identity and the sex assigned at birth. Gender is how someone outwardly communicates their gender identity through clothing, hairstyle, body language, etc. Gender incongruence is when somebody's gender identity does not meet that of the social norms associated with their sex assigned at birth. One step further, gender dysphoria is clinically significant distress caused when a person's assigned birth gender is not the same as the one with which they identify. There are disorders of sex development. You might have heard the term intersex. And these are individuals that are born with any of several variations in sex characteristics that don't fit the typical definitions of male or female bodies. Fairly common as those of us that have red hair at birth. A range of atypical sex characteristics can be obvious in the form of, say, physically ambiguous genitalia, but oftentimes there are atypical characteristics that are not noticeable at birth, such as having ambiguous internal reproductive organs or atypical chromosomes. Sometimes surgeries on intersex babies or children are performed to make their bodies fit into this binary idea of male or female. Transgender, which is really our topic for this evening, is an umbrella term for people whose gender identity is different from cultural expectations based on the sex they were assigned at birth. It is important to note that being trans does not imply any specific sexual orientation. Gender nonconforming is a term referred to people whose gender expression does not follow traditional gender norms that are expected of them. While many often identify as transgender, not all gender nonconforming people do. And finally, non-binary is an adjective describing those who don't really identify exclusively as a man or a woman. Non-binary people may identify as being both a man and a woman, somewhere in between, or nowhere on the spectrum. While many also identify as transgender, not all non-binary people do. Thanks to a few high-profile individuals, there is more visibility of the transgender community. I think it's important to note that Dr. Rachel Levine is the first openly transgender federal official to be confirmed by the Senate, and she is starting as Assistant Secretary for Health in the Department of Health Services. She's also a professor at Penn State, where she studies adolescent medicine, eating disorders, and transgender medicine. Lesbian, gay, bisexual, transgender, and queer refers to some of the minority identities and communities that exist related to sexual orientation, gender identity, and sexual development. The plus at the end can refer to the existence of many additional identities, as well as allies. You might sometimes see an A, an I, or a 2 at the end, which can include intersex, asexual, or two-spirit, as used by some Indigenous communities. There are 1.4 million transgender adults in the US, or 390 in every 100,000 population. There are 1 in 137 American teenagers that identify as transgender, and this is likely an underestimate. This number is actually expected to increase. We know through many studies that transgender patients have impaired access to and acceptance into the healthcare system. We also know that healthcare outcomes are different for transgender individuals. They have higher rates of mental health disorders, substance abuse, and disability. There was a large study in 2015 of the transgender population in the United States, and they surveyed 27,000 transgender folks. And 1/4 of these respondents did not seek medical care due to fear of being mistreated. 1/4. 1/3 who actually did go see a clinician in the past year reported at least one negative experience related to being transgender. That could have been verbal harassment or even refusal to be treated because of their gender identity. There is also violence in this community. Intimate partner violence has been reported to be 30%. There is also an increase in crimes against gender nonconforming persons. Last year, there were dozens of transgender and nonconforming people that were murdered, most of whom were Black and Latinx transgender women, some of whom I have listed here. Compared with the general US population, transgender individuals have higher unemployment and lower socioeconomic status. They are less likely to have employer-based health insurance or any clearly identified primary care doctor. Even transgender patients' health insurance have difficulties obtaining high-quality health care. For those of us that take care of the pediatric population, transgender youth have a high risk for depression, assault, smoking, eating disorders, and body dysmorphism. There is a rate of 14% of suicide attempts. The development of secondary sex characteristics during puberty can be traumatizing. Pubertal development can lead to greater anxiety and greater suicidal thoughts. The goal of pubertal suppression in gender dysphoria is to prevent the development of these unwanted secondary sexual characteristics of the sex that was assigned at birth. There is very little formal training available in transgender health, which is necessary to prevent stigma, discrimination, insensitive behaviors, and inequities of care. There are proposed best practices for transgender affirming hospital policies, and there are free online courses and modules. In a survey of medical students at the University of Ottawa, 42% of students reported anti-LGBT jokes, rumors, or bullying by fellow medical students or even other members of the healthcare team, and including attendings. A study of second-year medical students in Chicago found that 1/4 believed that homosexuality is immoral, and 9% believed it to be a mental illness. In another survey, general surgery residents witnessed homophobic remarks by a colleague or a staff physician half of the time. In a survey of LGBTQ providers, 10% were denied referrals from colleagues. 15% had experienced harassment by a colleague. 34% had witnessed discriminatory care of an LGBT patient, and 65% had heard derogatory comments about LGBT individuals. There's some hope. In a training that was formulated at University of California, San Francisco for second-year medical students, those that participated in this curriculum had an increased understanding of barriers of care, an improved knowledge of LGBT relationships, and these medical students demonstrated an increased willingness to treat patients with gender identity issues. There is a critical need within our medical training to have the skills to provide culturally responsive, culturally sensitive, and inclusive care. There have been standards of care for the health of transsexual, transgender, and gender nonconforming people that have been published. And in fact, there is the Healthcare Equality Index, which is a benchmarking tool that evaluates a healthcare facility's policies and practices related to the equity and inclusion of their LGBTQ patients, as well as visitors, as well as employees. What steps can we take as orthopedic surgeons to better care for our transgender patients? Be open and curious. Seek more information and training. Be aware of the environment and discriminatory behaviors and comments, and step in where appropriate. Be an advocate. Be an ally. Try not to make assumptions. And when in doubt, ask. Little shows of support go a long way. I cannot tell you how many patients and families have told me how much they support or they appreciate my support by wearing this rainbow lanyard. Don't assume someone's pronouns based upon how they look. Ask which name and pronouns they use upon first meeting them, recognizing that these can change over time. Try your best to use gender-neutral terminology. Try to use significant other or spouse rather than husband or wife. Try to utilize parent rather than mother or father. We know that failure to be identified by one's chosen name or pronoun has deleterious effects on satisfaction of care as well as quality of care. I have had the mistake of saying preferred pronouns, and I was taught that it's simply asking what pronoun do you use and not what is your preferred pronoun. I still have a difficult time for an individual using they, them, and theirs, but I am working on it. Certainly have not become accustomed to using Z, here, or here's as in the bottom row. I think it's really important to understand that messing up is actually part of the learning process, and mistakes are proof to individuals that you are trying. IT should be leveraged to provide better care. Interestingly, all EHR systems that were labeled under the DHHS Meaningful Use Program as certified are actually required to have the capacity to record sexual orientation and gender identity information. However, this rule does not actually require institutions to collect or utilize the information, just simply to have the ability to collect that information. I feel very privileged to work in an institution that does use our IT system to understand more about our patients. This is a fake patient, but you can see here that this patient's name is Lisa Rodriguez, but in quotations, they prefer to be using the term Leo as opposed to Lisa. And if you look here under the male icon that has a little I can click on that and get more information about Leo. And what I see here is that Leo prefers to be utilizing the name Leo and not Lisa. The pronouns he uses are he, him, and his. He identifies as male, but is born legally as a female and has female parts. So before I even go to the room, I know a lot about Leo and helps me take care of him. I also feel privileged to work in a place that has a program that really specializes in the care for differences of sexual development, gender development, and various urologic conditions. Our program, my children's, is called the Thrive program, which is called team-driven healthcare that respects individuals and values emotions. And it's truly a multidisciplinary system with behavioral health, adolescent medicine, gynecology, genomic medicine, and knowing what your institution has to offer your patients is actually helpful as a resource that you can send families to. In conclusion, an increasing proportion of transgender patients are going to need culturally competent care. Knowing the unique issues and concerns will help us provide the highest level of care, and we should continuously work to provide inclusive systems of care, correctly identifying and integrating this clinical information. Thank you.
Thanks very much, Dr. Samora, for that excellent talk. We'll now move on to Dr. Carter's talk on care of the transgender athlete.
Great. Julie, would you just give me a thumbs down if you can't hear me? I'm going to assume you can. I'm delighted to be joining, as was mentioned, this all-star panel. I have a background in sports medicine, and so I will be speaking about orthopedic care for the transgender athlete specifically. I have no disclosures. The objectives for my talk will be to identify barriers to sport participation for transgender athletes, to consider the musculoskeletal injuries and issues that transgender athletes may be uniquely vulnerable to developing as a result of medical and/or surgical gender-affirming treatment, and also to become familiar with existing data, which are sparse, on musculoskeletal injuries and issues experienced by transgender athletes. So to start, you've heard a little bit about this, but so transgender athletes identify as a gender different from the sex designated at birth. The prevalence of transgender individuals in the US is, as you heard, about 390 per 100,000. And so being a transgender individual or having a transgender individual in your orthopedic practice is pretty rare. And unfortunately, transgender athletes are disproportionately underrepresented. We know that, that transgender athletes or transgender people in general have lower levels of physical activity and sport participation than are reported in cisgender individuals. And there is little research and little data to inform musculoskeletal healthcare decisions. So going from there, let's begin by speaking about some barriers to sport participation. And they are manifold. One is simple limited access to an inclusive sporting environment. This may be because of inadequate changing facilities or the proper locker room. This may be more innate or intrinsic, so with personal body dissatisfaction or a fear of not being accepted by teammates, or it may be reflective of prior negative experience with competitive sports or backlash from other athletes or parents. And so the pictures I've included here are some of those that kind of ripped from the headlines of a transgender athlete participating in track and field in Connecticut who experienced quite a bit of backlash from other athletes and parents. Medical and or surgical gender affirming treatment may in itself be a barrier to sport participation. This could be as a result of recovery and rehabilitation after surgery. Some surgeries actually require or bed rest is recommended. Some surgical reconstructions may be done in a staged or planned fashion, and this may interfere with training or competition. And additionally, there are some mandated waiting periods for participation after initiation of hormone therapy, depending on the organization. And a word about backlash. So, where does this come from? In general, and there's not time in this talk to talk about all of this, but in general, the argument goes that transgender athletes have an unfair competitive advantage. And oftentimes the argument is centered around testosterone. And the thought is that transgender men who are taking exogenous testosterone may have an unfair advantage compared to their cisgender men with whom they will be competing. Or the transgender women who may have larger muscle mass or higher circulating testosterone levels than cisgender women despite anti-androgen therapy. And this argument, in fact, has informed some policies. And so I'm going to just do a very brief overview of some existing participation policies. If we look internationally at international level of competition, the IOC and World Athletics in general allow transgender men to compete in men's events, and transgender women may compete in women's events if the total serum testosterone is less than 10 nanomoles per liter for 12 months prior to competition. This is potentially problematic because many organizations have sort of hung their hat on serum testosterone levels as something that is both measurable and modifiable. But we know that there's a large overlap in normal levels among cisgender men, among cisgender women, and between transgender women and cisgender women. And so this enormous overlap makes it difficult to understand what's normal and to understand what's fair. And additionally, there are no data demonstrating a clear and certainly not a linear, logarithmic, or otherwise predictable relationship between testosterone levels and athletic performance. And so, for example, if you look at, at gold, silver, and bronze on a men's podium, if you looked at those athletes' serum testosterone levels, they won't go from highest to lowest. And so it's not a one-to-one effect. And then additionally, we've heard a little bit about intersex athletes, but so a lot of this discussion has centered thus far on intersex athletes. This picture, for example, shows Caster Semenya, who is an 800-meter runner from South Africa. She's widely decorated, and she has naturally occurring hyperandrogenism. And as a result, the World Athletics has, over time, told her she's not allowed to compete unless she lowers her normal endogenous testosterone levels, either through medical or surgical means. And this has been something that has been in ongoing litigation. And I think you sort of have to push back on some of that and say, well, how is being born, with naturally occurring hyperandrogenism, how's that different from being born with enormous feet like Michael Phelps's, basically flippers, or just being born to parents with who have a lot of money and can support a lot of training or specialized gear? And so, I think a lot of these arguments are fraught and we are and completely understood. And some of them are frankly just complex. If we look at the NCAA participation policies, for example, transgender men who are not taking gender affirming hormone therapy may participate on either men's or women's teams. Transgender men who are taking gender affirming hormone therapy may participate on men's teams. Transgender women without therapy may participate on men's teams. Transgender women taking therapy for less than a year may participate on a women's team, but the team status actually has to be changed to a mixed status. And transgender women who are taking gender affirming hormone therapy for more than a year may participate on a women's teams. And if you thought this was a sort of confusing and convoluted, when you start to look at high school policies, they're incredibly variable and they're controlled by state and local governing bodies. And so really, participation policies are complex, they're convoluted, they're highly variable. They continue to be challenged and reversed. And this is because the science isn't really there yet to support at least some of the participation policies for transgender athletes. And so we're not gonna be able to figure it out, unfortunately, tonight. I wanna move on to thinking about musculoskeletal health for transgender athletes. And so first, I think if we could just start to brainstorm, what unique problems might we see? Well, we may see problems associated with medical interventions like giving hormones or blocking hormones or suppressing puberty. This may affect, for example, bone health. We may see more stress fractures if we're thinking about extrapolating from the female athlete triad literature. Maybe we'll see more joint instability with those who are receiving exogenous estrogen. So maybe we'll see more shoulder or patellar dislocations. Potentially we'll see more ligamentous injury like ankle sprains or ACL tears. And we can extrapolate this from ACL studies looking at cisgender athletes. And from these, we've learned that athletes in the preovulatory phase of their cycle may be more at risk for ACL tear. We know that estrogen levels correlate with ligament stiffness. And there's also some data that suggests that use of an oral contraceptive pill may actually be protective against developing an ACL injury. And so maybe we'll start to see more ligamentous injuries or fewer ligamentous injuries as a result of hormone therapy in transgender athletes. We can postulate as well that we may see higher rates of DVT. We know that estrogen therapy is a known risk factor for DVT, so this would particularly be affecting transgender women. And we may want to think about this extremely carefully following an orthopedic injury and or surgery. And then additionally, just in terms of thinking about general considerations for musculoskeletal health, what about those that are associated with surgical interventions, for example, like a breast augmentation or mastectomy? Would somebody who has undergone a breast augmentation be more at risk for having back pain? What about just general musculoskeletal injury? We know that kids, for example, when they grow very quickly, lose their proprioception. We know that pregnant athletes are more likely to be clumsier and fall. And so maybe would we see just general increases in musculoskeletal injury as bodies are changing? And this could be analogous to those situations. And there are also, we can postulate some considerations just for overall health. So we know that, that lower levels of physical activity and sport participation are more likely to be associated with depression, anxiety, as well as things like diabetes or cardiovascular disorders. And so these are things maybe we should look for as well. So now, what do we actually know? What does the literature tell us now that we've brainstormed the potential problems or issues that we might see in transgender athletes? Well, I've listed here a systematic review, fairly recent, that actually looked at bone health. What these authors found was a small increase in bone mineral density at the lumbar spine was demonstrated in transgender women who received hormone therapy. There were no bone mineral density changes in transgender men receiving hormone therapy. And actually osteopenia-related bone stress injury wasn't really reported. So this is good news. The one situation to be aware of is that a patient or an athlete who has had a gonadectomy with hormone therapy cessation would be at risk for low bone mineral density. And so regular screening in this situation would be recommended. In terms of what we know about ligamentous injury and joint instability, well, it fits on this slide. We don't know anything at all. And so this really is an area that is ripe for research. In terms of thromboembolism, again, I've listed here a recent systematic review, fairly recent, which again says that we know that there's a risk of DVT for transgender women on exogenous hormone therapy. And so what can we do to mitigate this risk? We can avoid using ethinyl estradiol. We can avoid the use of, we can use transdermal estrogen. Perhaps most important for those who take care of athletes, it would be to screen individuals for other risk factors that would put them at an even higher risk for a blood clot. And additionally, we can be cognizant of sport and travel related risk factors. For example, long plane rides that many athletes, especially elite athletes, are consistently doing. And so maybe these are athletes that we would have to be particularly careful in terms of prevention of blood clot. In terms of post-surgical considerations, not just for athletes, but for transgender individuals in general, it's not uncommon for patients to report chest tightness, neck pain, or even shoulder stiffness following mastectomy. Hip pain and groin pain and postoperative pelvic floor dysfunction are not uncommon after pelvic surgery. And so all of these things are reasons why we might see patients in our offices or in the training room. In terms of mental health, and I think we've heard about this a little bit already, and we'll probably hear about it again because it's such an important piece. So Valentine in 2018, this was another systematic review, demonstrated that transgender individuals, not just athletes, had higher rates of depression, anxiety, suicidality, and substance use. And looking at 1,600 transgender youth in 2018, and you already heard these stats, but they are dire. And I would say here that this is a problem because we know that in general, participation in athletics may be protective against this. And so making sure that we're able to keep transgender athletes, to get them in the game and keep them there in a way that is safe and inclusive is probably a really essential part of optimizing mental health as well. Other unique medical concerns for a transgender athlete might include just recognizing that they might require a therapeutic use exemption if they're on medications, including testosterone or spironolactone. And specifically the situation of a transgender woman who has not undergone bottom gender affirming surgery. Protective cups might be necessary for use in contact sports, for example, or knowing that these athletes may utilize the practice of tucking. And so actually it may present with genitourinary problems like a hernia or cystitis, or even dermatologic problems like fungal infection. And so in sum, transgender athletes are a particularly vulnerable population who have unique musculoskeletal health concerns. There really is a paucity of data driving both participation policies for transgender athletes as well as their musculoskeletal care. And so this is an opportunity for collaboration. And so I'm at NYU, I'm working on this musculoskeletal health survey for transgender athletes that has been sponsored by the Diversity Advisory Board for the American Academy of Orthopaedic Surgeons. But I think really the first step is starting the conversation, which is what we're doing tonight. And so I thank you for letting me be a part of it.
Thanks very much, Dr. Carter. That was an excellent discussion, in particular of all the places we still have research gaps that ideally some of us in the audience will fill in the next decades. We'll next go to Dr. Danoff, who's going to be talking to us about the medical aspects of transgender care.
I think you need to, do you need to stop sharing your screen or can I just share? All right, okay, everybody see my screen? So I've been charged, first of all, thank you so much for including me in this really interesting panel discussion, interesting presentations. I've been charged with talking with you about medical treatment in transgender care. It's obviously a complicated topic, so I'm just going to give you a brief overview. I have nothing to disclose, no financial disclosures. As you've already heard, and as you're of course aware just from experience in the world, there's increasing visibility of transgender persons and beginning to be increased visibility of gender non-conforming persons as well. In addition to the lay press, there's a lot of literature explosion. If you see from the right side of the screen to the left, in 1979, there were about 51 publications. If you search in PubMed citations using the word transsexual or transgender, you pick out 51 publications. And in contrast, by 2019, there are 1,539 publications. So there's a growing interest and growing knowledge, but there's still lots and lots and lots of room for additional knowledge. So I'm gonna cover a couple of things. I hope that you'll get a sense of why gender affirming hormone therapy is important. I think you've already been introduced to that in a very strong way. I think also I'll speak with you a little bit about what to consider before initiating gender affirming hormone therapy, what medications we use and why some of them are less favorable than others. What are the consequences, some of the physical things, and some, I won't really touch much on the emotional stuff, but again, you've already heard a little bit about that. How we monitor briefly, and also a little bit on future directions for research. So why is gender affirming hormone therapy important? And I think it's worth saying this over and over and over again. You've heard it from the first two speakers, and I would love to emphasize gender affirming hormone therapy can be a life-saving medical necessity, obviously in the appropriately selected patients. Mental health characters, you've heard a little bit already about suicide. The rates of suicide and attempted suicide in transgender persons is as high in adults, as high as 40 to 45%. And in transgender adolescents, there's data that suggests that as many as 50% of adolescent transgender persons have suicidal ideation. And importantly, when people are have the opportunity to be on gender affirming hormone therapy, the gender transitioning improves their quality of life dramatically, improves self-esteem, confidence, relationships, decreased anxiety, depression, and suicidality. And in this context, people are often interested in what the response to gender affirming hormone therapy, or how much do people ever want to get off of it? And the rate of regrets or detransitioning are exceedingly low. Very, very rare for people to change their minds, if you will, once they've been on gender affirming hormone therapy, between 0.3 and 3.8%. What do we think about when we're considering initiating gender affirming hormone therapy in adults? There are a couple of criteria, and different organizations have slightly different recommendations, but in general, before initiating therapy, you want to think about whether somebody has persistent, well-documented gender incongruence or gender dysphoria. And again, you've heard this, but I think it's important to point out that not everybody who's transgender is dysphoric or uncomfortable in any way. People, and actually the DSM criteria, the next version of the DSM is going to change from gender dysphoria and place gender differences out of that whole category that it's currently in recognition that this is not a mental illness, it's a difference. The capacity to make a fully informed decision and to consent to treatment, the age of majority has been reached in a given country, and mental health concerns, if present, should be addressed. I also think that it's important to emphasize in adults that a psychiatrist who has been felt by the community for a very long time to, in some circumstances, be considered a gatekeeper in a very negative way, that a psychiatric evaluation is not no longer considered, at least by the Endocrine Society guidelines, as a requirement for initiating gender-affirming hormone therapy. Any informed, trained physician who is competent in this area is able to do. So I have, on many, many occasions, initiated gender-affirming hormone therapy in people without sending them first for clearance, or if you will, from a psychiatrist. And I feel quite comfortable doing that. In contrast with adolescents, and I personally have not taken care of transgender or gender nonconforming adolescents, but I kind of subscribe to this with my limited experience, that in contrast to adults, in adolescents, before initiating gender affirming hormone therapy or puberty blockers, if you will, there's a recommendation that a qualified mental health provider is involved in the care. And I do think that that's a good idea. We always do this in a very thorough, very interactive way, and talk about the risks and benefits. And I think it's also important to address the things that might be reversible and the things that might be permanent when one initiates gender affirming hormone therapy. It's also critically important to discuss reproductive options. And I'm not going to go into detail about what those are, but they might include sperm or oocyte preservation, ovarian or testicular tissue cryopreservation. Is an amazing explosion of reproductive options that just weren't available 10 or 20 years ago. I think it's also important to note that some of these reproductive options may not be available to everybody because of cost. So it's pretty heartbreaking sometimes to have a discussion with people about reproductive options, and then just at the end of the road find that it's really difficult for that to figure out a way to pay for those options. What medications do we use for gender affirming hormone therapy? Well, there are feminizing regimens and there are masculinizing regimens. The feminizing regimens include estrogen and anti-androgens. And among the anti-androgens, there are a variety of things that we can use. One of them would be a GnRH agonist. And I was practicing at a VA hospital in Philly, and before that in Manhattan. And one of the things that's really nice about the VA system is that we are able to use GnRH agonists. I think that they're sensible. There are no, by the way, head-to-head comparisons of different feminizing or masculinizing regimens yet, or very, very, very limited data on that. So people are kind of using expert opinion to do what they think is best, and also what they are able to do with respect to cost. So I like using a GnRH agonist in a feminizing regimen because it enables you to block endogenous hormone production so that you can achieve the goals that the patient sets with you in collaboration. You can achieve those goals with a lower level of estrogen replacement or estradiol replacement, which is what we use. In addition to GnRH agonists, and many places don't have the ability to use because of expense, we use a variety of androgen receptor blockers. The most commonly used androgen receptor blocker would be spironolactone. And there are other options that often people will come to your office if they've already started on hormone therapy. And we can talk about those in greater detail if anybody has interest in that in the question and answer period. I will like to point out that there is an anti-androgen progestogen, cyproterone acetate, which has been used in England for a very long time. It's not available in the United States, and in fact, it's no longer available in England either. And that's because it's been associated with an increased risk meningiomas. So it's sort of off the market. I put progesterone in red as sort of a stop, but the use of progesterone is exceedingly controversial in gender affirming regimens. And again, there's very limited data on whether progesterone helps with breast development or not. I'm reluctant to use it in most patients, but we do always, because of the Women's Health Initiative, which indicated that progesterone might be associated with increased risk of breast cancer and so forth. And so I think I prefer less is more if it's working for the patient. But I've certainly had patients on progesterone who feel really that it's an important part of their regimen. In terms of the estrogenic medications that we use, you've already heard a little allusion to this, but it's very, very important to recognize that not all estrogenic medications are the same, and not all estrogenic medications are associated with the same risks. And so I just actually the other day got a call about using ethinyl estradiol. None of us would ever basically use ethinyl estradiol in this context, or we would strongly prefer not to. And likewise, we would strongly prefer not to use equine estrogen in this context. We would much rather, because of the safety in particular with respect to thromboembolic disease, we prefer to use estradiol. It is less thrombogenic, and it's also measurable so that you can monitor what's going on with the patient. The delivery mode for the estradiol can be one of several things. Again, my preference in patients who are comfortable with it is to use transdermal estradiol, because it probably, based on the best available data, is associated with the lowest risk of DVTs. But I've also used plenty of oral estradiol and occasionally use parenteral estradiol as well. The masculinizing regimen is a bit easier. Testosterone shuts off the pituitary axis more effectively than estradiol does. And so in the masculinizing regimens, I don't use GnRH agonists, for instance. And testosterone is available in a million different varieties. And people have different preferences. The one thing I would just emphasize here is that officially, if you look at the PDR, it says that testosterone, if you're going to use it, an injectable testosterone, it's supposed to be used IM, but there's very good data now from one of my endocrine colleagues demonstrating a lot of the patients will prefer sub-Q, and there's good data to say that sub-Q is every bit as good as IM, and you can use a smaller needle, it doesn't hurt as much, and so forth. So no problem using sub-Q testosterone. What are the goals of gender-affirming hormone therapy? You know, the party line is that we're aiming for a mid-normal range of the affirmed gender. But again, as you've already heard, measurement of both estradiol and testosterone is very complicated. It's not a simple thing. Number one, a lot of the assays are not standardized and not very good. There's also a very broad normal range. Different modalities of delivery can be associated with affecting sex hormone binding globulin differently. And that would influence the free hormone levels that are available. So I use the biochemical measures much more to make sure that I'm not giving somebody too much medication that might harm them. And it's very interesting that while we know that higher and higher and higher doses increase the risks associated with gender affirming hormone therapy, but we actually don't have any data supporting the fact that in the therapeutic range, just like you heard for the athlete, there's no data that says that a higher level of estrogen gives you a bigger breast. There are so many other things that influence the secondary sex characteristics that are desired. So again, less is more, as is assuming you're having an honest conversation with the patient sitting across from you. Some of these things are not yet included in some of the standards of care, but with the increasing number of gender non-binary people, some of the guidelines will need to reflect that. And so I now have patients on significantly more complicated regimes to meet with their desired goals. The contraindications to estradiol would be, a history of thromboembolic disease, pulmonary emboli, DVT. I would be really reluctant to start somebody on estradiol if they had a history of that. Hormone-sensitive malignancies, recent coronary artery disease or cerebrovascular disease, severe liver dysfunction. I pay attention, although it's not so clear in a lot of the guidelines, but hypertriglyceridemia in transgender women who I'm starting estradiol, because as you know from the use of birth control pills, estradiol can raise triglycerides significantly. So I don't say, gee, I'm never going to give you this. I say, let's work to figure out how to lower your triglycerides. And let's, there are a couple of, I might start them on a GnRH agonist and so forth. I don't do nothing, but I do like to try to get their triglycerides down lower than 400 before I would start somebody on estradiol. And again, with the discussion, people are I haven't had people like, I can think of one patient that I've had sort of an issue around who had a hormone sensitive malignancy and was kind of demanding testosterone in that case, and an active hormone sensitive malignancy. Macroprolactinoma, again, would be something that I would address with other issues and then deal with it as well. What are some of the changes that one could anticipate? And again, important to emphasize that the changes are very individual. Individual responses can vary and can be impacted by all sorts of stuff like genetics, age at the start of the treatment, of the intervention, et cetera. So the feminizing effects and the masculinizing effects, I'm not going to go through them each one by one, but they're pretty much what you would expect. I wanted to show you a little bit about what to expect in a few things. So with hair growth and sebum production, and this is all work, a lot of the stuff I'm going to show you is work from the Netherlands group, and they've had a gender clinic since 1972, and they currently have about 8,000 people in their group. And they've done just absolutely magnificent science on investigating some of the issues. So this is from that group, and in a transgender woman, you can see the time course baseline for 8 and 12 months and the decrease in hair production, although ancillary mechanical ways to remove hair is also often used. And decreased sebum production, and in contrast, the increase in hair over the course of a year in transgender, in a transgender man on testosterone. You see changes in total body fat, and this would be in a transgender woman, where you see an increase in total body fat, and in a transgender men, you see an increase in lean body mass, which I thought might be interesting to this audience. Body fat redistribution can be expected. And you see in the 19 trans women in the left-hand side and 17 on the right-hand side, you see that redistribution with an increase in basically pear shape in the trans women and apple shape in the trans men. I think this is kind of interesting, the time course of breast growth. This is one of the earlier studies that and it's very recent, but that's actually looking an effort to quantify and to look at the time course of breast growth in trans women given gender affirming hormone therapy. And you can see it's the peak of growth is in the first 6 months. This group has carried this study out now to 3 years. And while you do see a plateau, you do see in the 3-year study an ongoing modest increase in breast growth. I also think this is kind of important to show in the right-hand side, where you see that irrespective of the dose of estradiol that's given, there is not a relationship between the dose of estradiol and the degree of the amount of breast tissue development. Again, sort of indicating that, at least in this situation, more is not necessarily result in greater development. What are some of the risks? You've heard DVTs is a big one. And I think for this group also considering perioperative management concerns, and there's just no good guidance in this yet. So somebody, I hope, will be doing this study. You know, when I think about this, many people will recommend stopping estradiol 2 weeks before and 2 weeks after a surgical intervention. But when you think about it, I'm not sure that really makes any sense at all. I mean, we don't, as far as I know, you probably all know this better than me, but I've never heard of anybody timing surgery based on the menstrual cycle. So I'm not sure it makes a lot of sense, but I think we need more data to know about that. The other concerns, again, we've addressed impact on fertility, impact of malignancies, and I'll show you a little bit more about that. Long-term cardiovascular health, and I'll show you another slide on that as well. But I think within the cardiovascular health concern is issues that have been addressed around impact on lipids, impact on insulin resistance. There clearly is an impact on lipids. Insulin resistance is sort of not so convincing to my mind. The impact on bone health you've all heard about. I think very important again to emphasize the special issue in that regard with adolescents. So with adolescents, we would start them initially before introducing sex-steroid hormones. Adolescents are started on GnRH agonist as a puberty blocker, if you will. And so at the time when they're on that puberty blocker and have no sex-steroid hormone, there's a lot of concern about what's going to happen long-term to their bone health. And that's also obviously a time of increasing bone accrual. I also have concerns about that with non-binary people. I think it's really important to make sure that that LH and FSH is not elevated in people, basically. It's a good way to monitor. In other words, that somebody has sufficient estradiol and or testosterone to protect their bones. And there's also some concern about potential immune stuff. In terms of malignancies, there is
yep. Dr. Danoff, I'm so sorry to interrupt, but we're getting kind of close to 9. So if you don't mind, I'll just ask you to wrap up quickly. Absolutely. So that
yes,
the next speakers can go, if that's okay. I do apologize very much.
No, it's my apologies. My apologies. So concerns about cardiovascular health and malignancy. And then I think just the unanswered questions, and then I'll end with that, which is, you know, what's the etiology? Nobody knows. It's a mystery. We believe it's biologic. There's lots of data that seems to be supporting that. What are the optimal hormone regimens? What about reproductive health, long-term consequences, optimal care of the kids, improved surgical interventions, and how to improve our clinical competence? I think in kids, the ortho questions, I think, you know, we've talked about a little bit, impact on of bone health from puberty blockers. skeletal issues, muscle strength, the athletics, perioperative hormone use, and cultural competency when dealing with trauma as well, which unfortunately lots of transgender and gender non-binary people experience. So I will stop there. My apologies for going over, and thank you for your attention.
Thanks so much, Dr. Danoff. Really appreciate that medical information, which I'm sure is new to many of us in the orthopedic world. Next, we'll be hearing from Dr. Tetreault. Dr. Danoff, if you could just stop sharing your screen, we'll get Dr. Tetreault's slides up.
All right. So my name is Tyler Tetreault. I'm a chief resident at the University of Colorado. I'll be doing my fellowship next year in pediatrics at CHLA. And I'm going to talk about how to be an active ally to transgender patients. Objectives for my talk. First is to understand that allyship is an action and not a state of being. To demonstrate the importance of allyship with trans patients, and to provide some guidance on how you can become a stronger ally for your trans patients. But first, I'll give you a little bit of background and why this is so important to me. So I grew up in South Jersey. I went to UPenn for undergrad, where I studied biophysics, and I was a member of the women's cross country and track and field team. During my time in college, I did come out as queer, and I was an active part of the LGBT community at Penn. And then I went up to Boston for med school, and I went to Tufts. Going into med school, I thought that I was interested in orthopedics, and this was my goal throughout, and I was lucky to match in 2016 at the University of Colorado. When I started at Colorado, I was only out LGBT member in my residency. And the next few years for me were quite busy, as are most residency programs. I didn't have much time for exercise and family, let alone to do something such as explore my gender identity. But luckily, during my third year, things slowed down a bit. And once I had some time for myself, I realized that I didn't identify as female. And over a few hard months, I came to realize that I did identify as transgender. And I was terrified. I was terrified that that meant I was going to have to end my career in orthopedics. I couldn't picture or imagine the discomfort that my patients would feel coming in to see a doctor who ended up being transgender. And I was getting ready to apply for fellowship, and I just couldn't fathom that my mentors would be supportive of me in applying fellowship, which in retrospect just sounds absolutely crazy, but that's truly how I felt at the time. But I also knew that I was really unhappy. And so with the help of my fiance, I started to come out to my close friends, my family, and some of my mentors. And about halfway through my third year of residency, I began to medically and socially transition at work as well. And in general, responses were supportive. They were uncomfortable and difficult conversations to have at times. But for me, really, the highlight was the folks that stepped up to the plate. And some of my mentors, without my asking, really stood up and took action to show me that I was a valuable part of our community, that my feelings were validated, and they encouraged me to continue along the path that I was on. So obviously this is very important to me, because without my allies, maybe I would have not continued in orthopedics. But long story short, to be an ally for a transgender person means to take action. And so that's exactly what an ally is. An ally takes action to support members of an underrepresented group. It's not just a statement of tolerance or statements of support. It's truly going a step further to support anybody that's part of an underrepresented group, but trans people in particular, we'll talk about. And why is allyship so important? When you take an action to be someone's ally, you're validating their experience. Not only are you telling them your support, but you're demonstrating it. And by taking an action, you also serve to improve the position of others. And so as providers, we have the opportunity to create conditions for trans people to receive the best care possible when they're seeing us. And so how do you do this? How do you become an active ally? Well, luckily, there are a lot of ways. but I think one of the most important, Dr. Samora touched on it briefly earlier, is to practice using appropriate pronouns and to normalize their use. This means adding your pronouns to your email signature, as well as asking every patient that you see for their pronouns. And this can be challenging at times, especially if you've known someone before and their pronouns have changed. Mistakes can happen. The best thing to do is correct yourself, acknowledge your mistake, and move on. And with practice, this gets easier and easier. They, them pronouns can be more challenging, especially from a grammatical standpoint, but it is important to your patients, and no doubt do they appreciate your efforts. And it's better to make a mistake and acknowledge it and then move on. And also, by doing this with patients that aren't necessarily out as trans, you can show your support for the community. And so if someone is transgender, but maybe they haven't transitioned yet, or they're not out, demonstrating this practice shows that you care about their community, and hopefully you become someone that they feel they can trust should they decide to transition down the road. In addition, this normalizes the practice for cisgender people. And so by the more people that use pronouns on a daily basis, the more normal this becomes, and then it's no longer a big deal and just part of daily human interaction. And then a note on the medical record. I found a few times in my experience when I see trans patients that the pronouns listed are often or can be incorrect. And this can be because someone has begun their transition since they were last seen in their clinic, or they might just not know how exactly to change them on their record. And so by asking about them, you can confirm that the ones that they have listed are correct. And if not, you can help them with that through your clinic. And this is another great way to demonstrate your allyship. And while orthopedic providers might not necessarily be involved with all of the small details of transgender healthcare, we often, we can also have the opportunity to offer our support. Sometimes this can be just as simple as acknowledging someone's transgender status. Imagine if you were trans and you came into clinic to see a doctor, and you knew that your medical records said that you were trans, and you also had hypertension, and your doctor was asking about your medical history, and they acknowledge your history of hypertension, but don't necessarily acknowledge your trans status. For some, maybe that's what they would hope for, but for others, it can make them feel like they're unseen, that their trans status is not valid and not worth discussing or talking about. And so it's important, if the context is right, to acknowledge someone's trans status when it comes up as well, just as if you take any other medical history. This can also open the conversation with your patients, and maybe you find out that they just moved to town. They haven't had a chance to find a new endocrinologist yet. And now, after Dr. Danoff's awesome talk, understanding some of the basics of transgender care, you can help them out. You can send them in the right direction. Being familiar with the providers in your healthcare system that specialize in transgender healthcare can be incredibly helpful, and you can make sure that they're getting to the providers that they need. And lastly, this isn't always an easy thing to start, and it's important to recognize your own discomfort. But if you're respectful and authentic as you have these conversations, this can be an excellent way to add allyship to your practice. And luckily, we don't need to have all the answers. There are incredible resources available, both on a national and community level, that we can help refer our patients to, and also for ourselves, in order to continue to become better allies. Some national resources, such as PFLAG and the Trevor Project, are great for trans people, as well as their friends, family, and allies. And on a community level, universities with LGBT groups or community LGBT centers, or trans-focused multidisciplinary clinics can be a great resource. And having an idea of what is available for your patients can be incredibly helpful. One of my favorite resources, though, is social media, especially with younger patients. This is a huge source of information for folks as they begin to transition or as they explore their gender identity. Some of my favorites, Chris Mosier, he was the first trans member of Team USA for triathlon, and he's now a strong advocate for trans youth in sports. Chase Strangio, he is a transgender attorney for the ACLU who's involved with the Bostock versus Clayton County Supreme Court case last year, dealing with anti-trans discrimination in the workplace. And Susan Stryker is a transgender academic and gender studies professor who's been involved with production of multiple LGBT films. And so even if you just follow these people on Instagram, whatever your social media of choice is, it's a great way to stay up to date with what trans issues are current, and be able to follow along and kind of understand what your patients may be thinking about outside of their appointments. And ultimately, to be an active ally, we can educate others. It's imperative to speak up when you hear hurtful or transphobic dialogue, and encourage others to use appropriate gender pronouns when you hear them used incorrectly. I remember when I was a junior resident, I had not yet come out as trans, and I was sitting in a pre-op conference one morning, and one of my attendings mentioned that one of their patients was transgender, and then throughout the rest of this presentation, misgendered this person throughout. And I sat there and I was waiting for someone to correct my attending, and it didn't happen. And I felt terrible because I knew that I was trans, and I wondered about the kind of response that I was going to have when I did come out. So we have a chance to lead through our actions and lead by examples. And I'm excited to hear what Lisa has to say more on this topic. We're leaders of the team in our clinic, in our operating rooms, and in our hospital. And we have an awesome opportunity to help change culture. Thank you very much.
Thank you so much, Dr. Tetreault, for that presentation. We really appreciate your willingness to share personally with us. And I think we all learned a lot about how we can do better as allies from your comments. Now we'll go to Dr. Lattanza.
All right. Maybe it's because of 10 hours of talking on Zoom today. So anyway, starting over, I'm going to talk about how to build a culture that is inclusive in a department, an operating room, or wherever you might be. The same rules apply. And if you accept that culture matters, then you need to define the culture that you envision. I hear this all the time. Well, we want to change our culture. You can't just make the statement that you want to change your culture. There has to be more than just the statement that goes into that. You have to define the behaviors that will be part of that culture. And by changing the culture, it's going to help everybody to accomplish their goals. So what you're doing is creating an environment and a structure to teach and support the behaviors that you want to see, whether it's in your OR team or your clinic team or your faculty or residents or whoever it might be. So how do we do that in the current climate when we have a federal government that's trying to take away healthcare protections for transgender Americans? And I don't claim to be an expert on any of this. I'm just making observations. We have a country where 30% of folks openly say that they would oppose any laws that prohibit discrimination in hiring practices based on sexual orientation or gender identity. And we have a country where more than 50% of Americans believe that there's only two genders. And we've heard today that that's not the case. So what is the science behind all this? So we know from the science that gender exists in more forms than strictly male or strictly female. And we know that gender dysmorphia is not a mental condition. And there's research that confirms that transgender people are born with brains that more closely resemble the gender with which they identify rather than the sex that they were assigned at birth. And there's ongoing research with regard to what the hormonal impacts are on brain development during fetal development, yet still politics is somehow involved in all of this. Luckily, we have doctors that agree that gender affirming care is life-saving care and have come out strongly in support of this. This is a statement from the American Academy of Pediatrics stating that politics has no place here. And I think all of us in living through the pandemic in the last 16 months or so have seen how politics and healthcare don't mix. And I like this statement that transgender children, like all children, just want to belong. And I think that we can say that about all people. So the basic premise is that we all want to belong and be treated with respect and dignity. And how do we create an environment for that? Well, I like this saying that what you permit, you promote. What you allow, you encourage, and what you condone, you own. And that means that first you have to look at yourself and whether you're being an ally or not, as Tyler just spoke about. There are some general principles about supporting a diverse workforce, and that is prioritizing human dignity and opportunity for all, rooting out prejudice at a structural level through education, policies, and practices. Basic principles of developing and changing a culture in general are starting by building trust with whoever the people are that you're working with. And that happens in a circular manner by first being sincere about what you are trying to accomplish, being reliable and committed, showing integrity and competence, and as well as consistency. And all of these things over time allow people to trust you on your team. You need transparency. What is the culture? What do we value? And this is whether we're talking about faculty, residents, students, staff. There needs to be transparency and opportunities, and as unbiased as possible, whether that's with recruitment, who we're trying to recruit, how we're conducting our interviews, how we're presenting leadership opportunities and research opportunities, and even who we select and allow to come for sub-Is. Communication is key. You need to make connections with people on an individual level. Listen to what everyone has to say. No one person has all the answers. Be empathetic and follow emotional cues from your staff and colleagues. Don't assume good or bad things about anyone. And be transparent in the way you communicate. Modeling behavior maybe is one of the most important things. And I like the saying that the reality is that the only way change comes is when you lead by example. You can't expect people to be accepting of diversity if you yourself are showing your own biases. Prioritizing diversity, equity, and inclusion in all missions is critical. Hiring and promoting diverse workforce. It's not enough to just get diverse folks there. You have to promote those people as well. You need to show that you value diversity by inviting diverse grand round speakers and visiting professors, having journal clubs about diversity, equity, inclusion, bias, and wellness, having a zero tolerance for microaggression and bias, and demonstrating allyship and upstander behavior. Building and empowering team members is critically important by providing structured ways for feedback and open exchange, rewarding self-improvement, and encouraging safe failure. As we've heard before, we're all going to make mistakes, and we need to be able to recover from those mistakes. Providing context, goals, missions that are clear and consistent, and requiring accountability of everyone. Praising efforts. Praise is cheap, it costs nothing, and it's very, very important. And supporting independent ideas. Flexibility is also critical. Flexibility with work schedules, leave, promotion schedules, and valuing additional contributions equally, whether that's research or education. And investing in people. Diversity, equity, inclusion training, leadership training and development, educator training and development, grant writing support, and wellness. And I found this comment really telling. The CFO asks the CEO, what happens if we invest in developing our people and then they leave us? And the CEO replies, what happens if we don't invest in them and then they stay? And what we're really saying here is that we want to have the best people as part of our teams, those open-minded people that can help us with our culture. Being more specific about supporting transgender workforce, a lot of this comes from Harvard Business Review, and some of it comes from common sense and working in and knowing about diversity, equity, inclusion from other places. But basically what we want to do is send a message of value and belonging, and we want to do that with everyone. But there are some specific ways that we can do this with the transgender workforce. And some of these very simple ways are bathroom access for gender neutral or use of same as gender identity, making sure that dress codes are not outdated and are meeting our current goals. We've heard before about pronoun name and usage. We have to look at this on badges, emails, asking correctly what pronoun you like to use or go by, and apologize and correct when we make mistakes. Developing transgender specific workforce training as part of our diversity and inclusion training. and include transgender employees if they are comfortable. When possible, include contact with those that identify as transgender, or in lieu of this, include videos and stories from some of the other sources that we've heard of this evening and organizations that can provide this. One of the things that we know works the best in supporting diversity is getting allies from the community that is not part of the underrepresented minority. So in this case, providing opportunities for cisgender employees to become champions through education of others, advocacy through policy reform and implementation, and defending against bias and becoming upstanders, and through allyship. If gender transition is something that's happening in one of your employees, we need to first make sure that we have access to healthcare benefits that are gender identity specific and supportive of this, and do this on an institutional level. Listen to and collaborate with the employee as to what they need during that process and how they would like to handle it. And I think Tyler, I really appreciate how Tyler shared personal experience on that. I think will make us all better at doing this in the future. And if approached by the employee, our HR department should have resources to help guide the employees. And leaders and managers must proactively cultivate a supportive work environment and model this behavior. And then in general, in the workplace, we need to cultivate employee wellness strategies for reducing stress in the workplace. And this can be done through mindfulness training and cognitive behavioral training, as well as other type of wellness training. I like this quote by Brene Brown: "We're hardwired to connect with others. It's what gives purpose and meaning to our lives, and without it, there is suffering." So I think maybe the first thing I should have put in, the most important thing in creating an inclusive culture, is to create shared experiences for connectivity and belonging, and to stop looking at the differences, but to see that we all have much more in common than we have as differences. It might be easier to come in and start a new culture than it is to change a negative culture, but there are some basic tenets for that as well. And John Wooden said that the best way to improve the team is to improve yourself. And I believe that this is absolutely true. You have to look within first. Self-awareness is critical. Leaders have to examine their own behaviors and beliefs, and that's whether you're a chief or a chair, or you're the leader in the operating room or in the clinic. And you have to examine your own effectiveness as well. In terms of individual strategies, you have to recognize your own biases, ask for and listen for feedback, and don't defend when someone tells you that you have messed up. Just apologize and move on. Admit your mistake and try to do better the next time. When you're having a difficult time on your team, you need to also find your allies on your team and empower them and support them. And that will help you change that negative culture over time. Enlisting help from other places such as Diversity, Equity, Inclusion Office, the Graduate Medical Education Office, and also outside facilitators. This is something that we're putting in practice in faculty development. We have outside facilitators coming in that are helping us all become better leaders, better mentors, better faculty members, hopefully better human beings. And when push comes to shove, this is all a part of professionalism. And wherever we are, there are systems and things in place when we're having problems with individuals over professionalism. So in summary, creating an inclusive environment must be part of the strategic plan, not just because it is the best thing for business, but because it is the right thing to do. It doesn't just happen organically. We have to start from a place of open-mindedness and realize our own biases. We need to model good behavior and find allies and support them. And most of all, we need to listen and learn from each other.
Thanks so much, Dr. Lattanza. That was an excellent talk, and I know we all appreciate both your leadership and your example. We'll go now to the Q&A. I do want to be mindful of everyone's time, so it's about 9:22 on the East Coast. Let's say we'll go till 9:30, and we'll call it there. So first, I'd like to start with a question about the recent legislative effort in a lot of state legislatures to deny healthcare and deny sports participation to trans youth. I think a couple of the panelists mentioned it in their talks, but I'm wondering if, as a group, you'd like to comment on what you think the effect will be on both our ability to provide care for our patients and what the effect on the patients themselves will be.
I'll jump in just to talk about sports. I mean, I think, well, I love sports. I always played them. I believe that that sport is medicine, actually. And so, you know, I can list forever the number of ways in which sport or being physically active and sport participation is essential for bone health, for muscular health, for cardiovascular health. It is, you know, being physically active is protective against diabetes. We know that kids who are physically active are more likely to have higher grade point averages and do better in school. Their behavior is better. We know it improves self-esteem. And so, I mean, and so there's so very many reasons that affect every part, you know, of our systems to be physically active and to play some kind of sport. And to me, sports is an inclusive word. It doesn't mean you have to go play soccer. It means you do yoga or dance or hike or do something in which you're moving your body in a way that you find enjoyable. I think that systematically eroding that ability, again, to do it in a safe and inclusive way from early on is going to be detrimental for all the health systems I just mentioned. I mean, I think it has the potential to just be pretty catastrophic.
As many of us have said, it seems very clear to me, unequivocal, that some of the things that we've been talking about in terms of transgender care are life-saving medical necessities. So to contemplate the idea that patients won't have access to that life-saving care and that providers who provide such life-saving care can be put in jail is, it's horrifying. It's just horrifying. And I think we have to act. We have to be advocates and allies and politically active and speak with all the people in Washington that we can, and do the kind of programming that we're doing as well to make people aware of how important and life-saving this is. You know, cultural competency for all, not just for medical providers.
We do have a question from the audience on, are there challenges unique to transgender MSK healthcare providers, and how can we help improve these circumstances?
Can you clarify that a little bit? Are there challenges that the providers have in providing care, or in terms of actually like challenges based on the injuries or illnesses that we see?
I imagine there may be an element of bias that the questioner is asking about too, that providers who are themselves transgender, they may face some challenges, and how can we help improve their circumstances? I do think Dr. Tetreault talked about that a little bit in his talk as well, but maybe he or some of the other panelists would like to expand on some other ways that we can help support our colleagues in particular.
Yeah, I would say that there aren't a whole lot of articles out there on LGBTQ providers themselves. There are a handful in non-orthopedic literature, and it's not good what's out there. There is really not a lot of support for LGBTQ providers. I think some of the things that were already mentioned this evening are to really be aware of the environment and not being a silent bystander. Your silence really does imply your consent of derogatory language, of comments that are really inappropriate, that are so ingrained in some of our surgical world that we don't even think about it. But we have to actively think about what's being said and stepping in. And I think about what Tyler had talked about as a resident, as a junior resident, listening to an attending really not utilize the correct pronouns. It's hard as a young trainee on that hierarchical scale to stand up and say, hey, this is a he or a she. That's what they go by. Can you make sure you use that? That's not an easy thing to do, but wherever you are in the hierarchy, obviously it's easier from a position of power. Like Dr. Lattanza is a chair. She has quite a lot of weight in when she says use the right pronoun than a trainee. But I would say, if someone had the bravery to say something, you would be making a statement and really allowing others to speak up in these scenarios as well, but really that advocate, really promoting that culture of inclusion.
Yeah, I totally agree. I think Dr. Lattanza touched on a lot of ways that can help improve these circumstances. Being trans comes with some barriers that can distract you from what you're trying to accomplish at work and taking care of patients. And the more that we make those cultural and structural changes, the easier it'll become.
Thanks very much. We have another question on, is there data regarding expected physical changes in the patient based on age at the time of onset of treatment? I imagine that question is directed to Dr. Danoff about hormonal treatment.
There's not great data on that yet. Unfortunately, I think, it's one of the areas that people are actively investigating now. There's something in the ortho literature, actually, that was, one tiny little thing that I saw at a recent endocrine society meeting, where it looked like there was a difference in pelvic development in an android versus gynecoid manner if GnRH blockers were started early in puberty as compared to even just a little bit later in puberty. That's sort of a bit tantalizing, even in terms of athletic performance and that sort of thing, and orthopedic function or dysfunction. But there's a lot to be learned about that.
Thank you very much. One final question, I think that'll be it. One audience member notes that I find it difficult to pose the question of pronouns to many pediatric patients, and I'm interested in suggestions for being sensitive in a way that may be also sensitive to parental presence and age. I think that's a great question for anyone who is comfortable broaching this topic with pediatric patients and parents. So I'll look to the peds people, but adult practitioners can answer too if they have a good answer.
But what I will say is actually oftentimes by the time they're in, I'm sitting down with a patient and family, these questions have already been asked, right? Because our electronic medical records actually sort of require it. And so I'm not actually always the first one to bring it up. I think my approach is just to be very matter of fact about it, right? This is something I ask every single patient. It's because it's important to ask every single patient. And it's because if we assume, then you know what happens. And so I think being straightforward about it, and then if you get an answer that you're surprised by, actually not necessarily, handling it gracefully, and then maybe making sure that you're creating a safe space for the patient and family to talk about it. But I think the first thing is just to be matter of fact about it, rather than like embarrassed or just to have it not be part of just every single part of the discussion.
I would agree with that. I think when it becomes part of your normal way of approaching patients, then you get less uncomfortable with it. And having practiced for 20 years in San Francisco, I had a lot of practice with it, and I was very uncomfortable and bad at it in the beginning. And, just to make a comment, I had patients in San Francisco that transgender patients that felt like they had to bring people with them to support them in their medical appointment because they'd had such horrible experiences before that they would bring an ally with them. And that really hit home with me that we were doing a really bad job if that's what people felt they had to do just to feel comfortable to go and see their doctor. And I learned maybe 30 years ago from an instructor in physical therapy school that you should ask every single patient how they want to be addressed. It's just a respectful thing to do. And that's something I've done my entire career. So I think once you just start doing that, it becomes second nature.
Right. Well, on that note, thanks very much to all our panelists for their outstanding talks and expertise. I think we've all learned a lot from this session and look forward to more in the future. Thanks very much for your attendance and have a good night.
Thank you. Good night.
Thank you. Good night.